I think we've heard a lot of different perspectives about how to best invest in worker health to improve the performance of the company. What I'd like to start with, perhaps, is you, David, because you've challenged some of the status quo here. You make some strong arguments about what's needed in order to benefit the workers and the community, all the way up to health system strengthening and beyond some of the things that we usually think of in this country. I'd like to ask you how, and we also spoke this morning about the importance of policies in doing all of this. How will improved workplace health policies and practices help create shared value for the community? How will it go beyond the workplace?
Should I grab this? Thank you. That's a great question. And I think there's one of the things is, and we need more research on this, is I firmly believe what happens at workplaces around health and behavior change gets transmitted in the community, both by people going out into the community and sharing information and changing values and health behaviors and other things. But I think there needs to be a lot more research to see whether that's actually true. But, you know, there are other ways that factories can make and workplaces can make a big difference. So let's look at Cambodia. One of the problems in Cambodia and many countries is not going to health care service providers, but going to ones that are quality, that have good standards. So if one of the things, changing of the policies and practices of the workplaces is helping to refer workers to quality providers, not just any providers, and ones that are near to them, you start changing behaviors and you create a notion that when you go to a health provider, you don't just go to one that's nearest to you, you also go to one that is high quality. Another way we're looking at in the Cambodia project is this issue of how do you train nurses, and it's very expensive, and one of the things the NGOs say is, oh, well, we train them, and then after we go, they leave, and, you know, for the business, why should we training these people? We train them and they go. Well, that's a clear way you could think about how governments and public health processes for licensing and training and registration can be linked to the public sector, to workplaces in the private sector. So, you know, governments and private sector can work to say, how do we create a training program that trains nurses in how to be effective in a workplace, which is different from being in a public health clinic, even though there are overlaps. And that's one of the things we're hoping in the next few years to do in Cambodia, because one of the things, as we haven't talked about, there's all sorts of regulation. But companies and jointly industries can incentivize things to happen. So one of the things we're hoping in Cambodia we will be able to do is say, look, all factory doctors and nurses will now need to register and pay their dues to the professional associations. If this happens, you automatically start making those associations viable because they'll start having funds. And that will be a way both to improve the doctors and nurses and others in the factory, but it also strengthens a whole broader process is trying to strengthen the health system and the quality of doctors and nurses in the country at large. So I'll stop there.
Great, thank you. I'm going to ask one other question, and then I'd like to open it up to the audience. Yeah. Yes, please.
So I'd like to take a completely different angle to this, and based on research that Ron and I did in the past, it winds up actually that healthcare workers, at least healthcare workers in this country, are remarkably unwell. And also when you study how healthcare workers access the healthcare system, they don't do it appropriately. So healthcare workers overutilize all healthcare services in this country, except for the one that we might want them to overutilize, primary care. And so the healthcare worker, which you would hope would be a role model for the community, actually sets a very bad example in two ways. They don't take care of themselves and they don't navigate the system well. So from earlier studies, we know, for example, that 55% of nurses in this country are obese, meaning they have a BMI over 30. That doesn't mean that they're overweight. That means that they're way overweight. And what that means, for example, is that if it's true that 1/3 of the American population is obese, then 1 out of every 6 times that a nurse is helping a patient out of bed today in this country, it's an obese nurse helping an obese patient out of bed. And that's the reason why the healthcare industry has disability rates that I believe, based on OSHA reporting, are not that dissimilar from the mining industry. I think, you know, the best place to start for healthcare delivery systems is with their own workforce. And in fact, it's my belief that no delivery system in this country should be allowed to have an accountable care organization until they've demonstrated success in what I like to call their captive ACO, their own workforce.
Thank you. I'd like to ask one more question that anyone can feel free to address. Listening to all the presentations, it strikes me that there are so many different ways to look at what are the problems and how do we measure success, and what metrics do we use. What is needed to strengthen the evidence base really depends on what outcomes you're looking at. So from the different speakers, we heard about a lot of different outcomes, many of which are, you know, if not all, are very compelling. But which do we look at in terms of measuring the success and looking at whether we are, in the long run, really improving population health? This morning we heard about the importance of long-term thinking in companies. It seems like it's also important to think about long-term thinking in health. So we heard about outcomes such as building new hospitals, training nurses, access to health care, reducing risk factors, how much health care is utilized, how many chronic diseases are diagnosed and treated. But this gets back to we want to think beyond the number of diseases and the number of healthcare encounters to, are we really affecting a change in the population health? Are we decreasing the number of cardiovascular events, the deaths from diabetes or cancer, not just diagnosing more cases? So I just wanted to open it up and ask that question.
I'll take a first shot at that. And I think, you know, one of the points that I made is that it depends who the audience is. So if you've got a physician or an epidemiologist, they're going to have one set of outcomes. If you've got a Wall Street investor, they're going to have a different set of outcomes. And if you've got a corporate HR executives, yet a third. So I think these really have to be molded and shaped by the audience seeking those metrics. So I put them in these 3 buckets of the financial outcomes, the health outcomes, and the humanistic outcomes. And different people in this audience are going to have different areas of focus. Within the category, you can create standard metrics. And there are books on what those standard metrics are. But in terms of what's important to you, Mr. CEO or CFO or HR VP or manager, that's going to vary.
You're saying we need different metrics?
I think you can standardize metrics, like you can define what healthy eating is and what physical activity is and what stress and nutrition and anxiety and so forth. Those metrics can be standardized, but whether they're relevant to any given audience member will vary.
Very much. I think in the space that in training new ministers of health and ministers of finance, they get a bit overwhelmed with the number of metrics, and we show them what we do in the American healthcare landscape of thousands of metrics. You know, they turn a blind eye. And so one of the things that Julio Frank teaches in June is to think of the access a woman has, unfortunately, if they're in obstructed labor. And so if you have access to a C-section, then what funnels down from there, for example, is you have a referral base, you have transportation, you've had prenatal care, and so that helps the ministers hone in on, you know, one specific metric.
One of the things I thought was impressive about your approach is it's very problem-oriented. You really single out some of the most important issues and then look at solutions for those, which seems different than some of the other approaches.
Compliment. I hope compliment.
Compliment. Yes, Fred, could you?
Maybe I can add a perspective from the sort of investor standpoint, just to build on what Ron said. I'm looking at a case study here of an investment we made in Egypt 2 years before the revolution. Yeah. And lo and behold, this was a diagnostics laboratory. And even during the revolution, we continued to grow that company organically and also expand it to other markets. We listed it about 6 months ago on the London Stock Exchange. It's the first time that an Egyptian company is listed there. And our investors made 2.2 times their money in 7 years. What are some of the sort of key buckets that we looked at in terms of metrics? First of all, it was the ecosystem build-out. So how did we expand and scale that company? How did we roll out additional facilities? How we improved the management of that company, and how we created more managerial capacity, because often in the companies and markets we're operating in, it's the actual managerial capacity that you need to improve. We look very much at the clinical staff addition because of the gap that needs to be filled. The operational improvements that any private equity firm would do in any kind of company. And finally, we do factor in how we increase the reach to the low and middle income class of that given market. So these are some of the metrics that we look at. They're financial, they're performance, but they're also social performance factors.
Thinking that there's a lot of people out there to reach in the lower income class, so the more that you can get to them, then the better performance, the more opportunities the business has.
And since I have the mic, I just wanted to say I really enjoyed what David had to say about the company really being at the center of the community. And I think that offers an opportunity for whatever kind of company, whatever sector you're in, to have a positive impact outside of the workplace. Inside the workplace, yes, but outside of the workplace too. And one of the notions that we are trying to also tackle is that you don't have to be a large company with large amounts of resources to achieve that. SMEs are also very well positioned to be able to have an impact in their communities. And working in, we have 150 companies in our portfolio across these markets. We have tons of case studies and proof to that matter. So I'm very optimistic about the changes and the mindset shifts that I think are starting to occur, and would also encourage the U.S. to look at some of the models that are starting to be developed in these emerging economies, because not everything has to be a Western-based model. There are extraordinary new models that are emerging in these new markets.
Great. Yes, let's, Ben.
Figure out which button. Yeah, thanks, Jessica. Okay, so GE, some of you know it pretty well, is a large global multi-site employer. We're heavily invested in the emerging markets. We've spent a small fortune on trying to develop a culture of health and trying to manage our healthcare costs everywhere. The reality is that we continue to see unsustainable costs in the U.S. We see incredible demand for U.S.-like benefits in the emerging markets. The health of the population in many of the emerging markets is really bad and getting worse, China being a really good example of that. It gets to the point where the cost of health to the company has gotten to be really hitting the bottom line in a way that is very frightening for U.S. multinationals. Any advice? I mean, you've given a lot of stuff up here, but at the end of the day, people like me, we have 300 clinics around the world. We have a very complicated health promotion program. Ray, I think you were even involved in helping set it up. But the reality is that its impact, and we're not different than most of the large global manufacturers and companies around the world. We have good intentions, but I'm not sure it's successful.
Sure.
Well, Ben, I would say, just to put GE in some perspective, based on my analysis of where General Electric is relative to most, they are hitting on many of the 218 elements that we have identified that make up a culture of health. With that being said, I do know, having been in there, but albeit a while ago, and what I know now, that there are some remarkable gaps from benchmark that General Electric is not exercising right now to do what Ron has talked about from, for example, Peter Wald at USAA, surround the workforce in a culture of health. And yet, I think the gap isn't that big, and as a consequence, I think the experience General Electric has had, at least in terms of healthcare costs, is moderate relative to others, but not flat yet or sustainably under control. The fact that other companies like Dow Chemical, for example, worldwide, or Johnson & Johnson worldwide can achieve this means that it is achievable for General Electric. Now, there are headwinds, and I appreciate them, especially in emerging markets. And maybe what you need to set as a goal isn't necessarily flat healthcare costs, but at least the achievement of decreasing health burden over time.
Let me also, agree with Ray. He's got, 200 some odd metrics. Community Guide has about 200 different metrics on culture of health and how to achieve that. But the other important factor is it's a product. You're selling health to your workforce, and some of the product elements are going to work and some are not, just like anything else, refrigerators and stoves and whatever else. You've got to test those products out and see if they resonate to the workforce, whether people like these products, they participate, they think it's going to make a difference, they become engaged, because ultimately, at the end of the day, it's not the company that decides the health and well-being of the workforce, it's the individual worker who says, this is something that's going to benefit me and my family, something I'm going to adopt because it's a good idea for me, not just for General Electric. And you've got to test those different products, different approaches out to see which ones of the 200 some odd interventions or initiatives work.
Can I just ask, Fred, I'm interested in how you view the culture of health. And when you are making investments, how important are these metrics that we're talking about? Ben's facing rising costs, and he's trying to create this culture of health. Is the culture of health something that you would take seriously, or?
We actually call it common sense. It's not that we have a myopic focus on just health, but when you're investing in the markets we're in, the gaps are just so obvious, whether they're in terms of governance or in terms of health and safety or in terms of training needs. And I'm actually quite surprised by this conversation here and hearing how U.S. companies are facing such difficulties in terms of promoting a culture of health in their companies. This is actually a huge learning for us because we're going around the world saying, in Europe and in the U.S., it's probably you just do it. But it's common sense. But in fact, I'm realizing from this discussion that there are huge challenges. I guess that for us, it's the leapfrog. Opportunity is easier to do because we're investing into medium-sized companies, and they're in great need of institutionalization. So it's not just about the business and the core business itself. It's also about the way that business is run. And if we had more time, I would tell you about the story of the Karachi Electric Supply Company that we invested in 7 years ago, which was just a completely broken, corrupt company, losing $1 million a day, and how we've been able, last year it's running $300 million EBITDA profit and is a completely new company. By applying common sense, and a lot of that has to do with centering the company in the community, and health practices were also, of course, very important.
That's terrific. Do we have time for a couple more questions? question? Okay. Yes, go ahead, please.
Hi, my name is Shanaz Raji. I'm with Vitality. And just listening to a lot of what you were saying, I wanted to bring up a report that we actually put out through the Vitality Institute this summer, funded by Robert Wood Johnson, and looking at community health and how companies can make that investment, taking what they're doing internally and taking a step further, especially because there are a lot of case studies in here. Some of the companies that you mentioned are reflected, and we really try to go beyond just sort of like a nice write-up and talk about some of the challenges and really how they get to measuring impact and taking it a step further. So I'm happy to share that.
Thank you.
It also should be it also should be mentioned that the HERO organization has actually partnered with the Institute of Medicine and the Academies and done a market scan of all of the best efforts in terms of community workforce, community employer partnerships, and that's available on the HERO site, on a sub-site that's called Healthy Workers, Healthy Communities. Right.
Any other questions? Yes.
Hi, I'm Purvi Bhatt again from Medtronic. I just found it fascinating that the returns on culture to health are really as productive as they are, and just wonder if there's an opportunity to connect CSR efforts around supply chain to what's happening for the multinational company. I happened to have, at one point in my career, some time with Levi Strauss, and so there was a lot of work around terms of engagement and real expectations on what one would have for a distribution chain or a supply chain and their expectation for health, and wouldn't that just leverage even greater gains for the multinational? So just trying to connect some of the work from David into what Ray and Ron were talking about and connect it back to CSR again as well.
There's a great book out called Firms of Endearment. I don't know if you know about this book, but I thought others might have mentioned it earlier today, including Mark Kramer. But this is a book now in its second edition that studies those companies that are loved by all of the constituencies in their, let's say, supply chain. So their customers love them, their vendor partners love them, their shareholders love them, and they are therefore given this title of Firms of Endearment. When you study the investment of portfolios of Firms of Endearment, they remarkably outperform as well.
Just one note on corporate social responsibility. One of the 3 papers that will be published in January does emphasize the role of health promotion, disease prevention, and community engagement with corporate social responsibility as one element. It is one of many elements, but it's probably a very important element because it very much aligns with job satisfaction, which also has been shown to be a major predictor of company success.
Thanks, Harvey. That's, when Fred, you were talking, I was thinking about this in terms of metrics around supply chains. And obviously, there are companies in their value chains that have huge hospitals and really first-rate clinics. So there's a huge range. But I'm really convinced in the work I've seen with Levi's and BSR and others that health in supply chains and how it managed is a really good proxy for industrial relations, the management quality of the workplace. And that if you can capture that, you can capture some of the risk in the world. Are they going to blow up in strikes? Are there going to be other kinds of problems that you can't get necessarily directly, but can do it? I would just say one of the things I cut myself short was on Levi's, which I think, the importance of the broader structures, incentives on business and supply chains. Obviously, financial markets and investments are a huge part of that. And Levi's, as you probably know very well, has just done this partnership with the World Bank, where they are helping to underwrite loans that the IFC will provide to their supplier companies who meet their code of conduct. And their code of conduct is tied into health and other things. And it's an interesting way to start thinking about how you use these incentives, financial and market incentives, to breathe life into standards and compliance that really is very poor, and it's what makes people say CSR is just, greenwashing or whitewashing. But I think there's a a huge world where health and these kinds of things and using financial markets and marketing can make a big difference in what happens in the supply chains and health within companies and how that can affect communities.
It's fascinating. We clearly have a lot to learn. Yes.
Hi, Kathy Taylor from the University of Notre Dame. I just wanted to comment on something Frederick made that made me think a little bit about, you're wondering about the culture of health and well-being. And it seems to me, at least this probably applies more to the U.S. than low and middle-income countries, but we have such a fragmented health system. So from the perspective of a corporation, it makes perfect sense to promote, healthy lifestyles, preventative medicine, population health. But that is in contrast to a large for-profit healthcare industry in the U.S., and then other fragments of our veterans care that's funded by the government. And I wonder if you could just speak to the impact that one might be having on another in terms of their success. Well, she
I'll take a shot. I mean, you can think of companies as microsystems or macrosystems, so they have humongous control over the workforce in terms of policies, programs, incentives, communication, data, which is why I think that's a starting point for creating population health. If you wait for the government, especially this government, to all of a sudden introduce innovative programs, it's not going to happen. But if you think about, 155 million Americans going to work every day and spending most of their day at work, all of a sudden you have a major captive audience that you can provide the kind of health education, health promotion that the government will never try to do. And most of the services in healthcare are really treatment services. It's after you've gone over the cliff, how do we get you the best care possible, which is really expensive. Focus is not on prevention, health promotion. It won't be with government auspices for the near future. So I think an industry has a major role to play, and it is in their self-interest to do these kinds of things.
As a physician who actually has played leadership roles in the provider community, in the payer community, in the purchaser community, in the informatics community, in the pharma community, it's become more and more clear to me what Ron is speaking about. If you look at the determinants of health, the employer has many, many more levers to pull than a delivery system, an insurance company, even the family itself, because, of course, the employer has an opportunity to provide employment, a greater sense of purpose, an opportunity for advancement, income, an environment that's healthy, benefits that can provide incentives for a healthier opportunity, and actually provide access to health care on site or nearby. I mean, that's just to name a few. And there's no other constituency in the healthcare world that has the opportunity to impact on so many determinants of health.
Good point. Thanks. I'm sorry I have to close this. We want to have time to go to lunch and come back for the afternoon. I want to thank all of our panelists very, very much. And we can continue the dialogue over lunch. I'm sorry to leave a few questions unanswered.